Just one. So today we are very honored to have an outstanding panel of national level thought leaders to talk about the future of telemedicine. We will begin with a keynote talk by Dr. John Glaser, who is currently executive in residence at Harvard Medical School. He has been with various healthcare providers as well as the private sector, delivering tremendous innovation across the board. He was previously with Cerner Corporation as an executive, and previous to that was Siemens Corporation. And prior to that, he was at Partners Healthcare as Chief Information Officer. He was also the founding chair of the College of Health Information Management Executives, CHIME, and he's been past president of the Health Information and Management Society. He has won numerous awards and is regarded as one of the very top thought leaders in healthcare. So we're delighted that he's giving us the opening keynote talk. We're also very excited to have Dr. Christy Henderson, who is with us, and she is CEO of Optum Eye Care, and she is the current board chair for the American Telemedicine Association. On one of the other panelists is also Dr. Atif Mehrotra, who is here at Harvard as professor in the Department of Healthcare Policy at Harvard Medical School, and he is also on faculty at Beth Israel Deaconess Medical Center. He leads many national level studies on telemedicine and healthcare policy, and we're delighted he is with us. We have also very excited to have Dr. Amar Gupta, who is a principal investigator on telemedicine projects for many decades, and he is currently at the Massachusetts Institute of Technology, and he is also editor-in-chief of Telehealth and Medicine Journal today. And he has led many initiatives in Arizona, New York, and we're delighted he is with us to share his expertise. And we are exceptionally excited to have Dr. Roy Schomburg. Dr. Schomburg is president and CEO of Amwell, one of the largest telemedicine companies in the world. He is also a graduate of the Division of Clinical Informatics. He completed his informatics training here and has had tremendous success with his corporation and impacting healthcare, and brings us the perspective from the projects that he has initiated. So really, truly a top-notch field. And let me pass it over to Dr. John Glaser now, who will begin with the keynote talk. Thank you.
Thank you, Yuri, and it's a pleasure to be here to spend some time with all of you, and a pleasure also to be surrounded by this all-star galaxy panel that you'll get to hear from shortly here. So I'm going to start my presentation in about 2 seconds. I apologize if I have to cough or sneeze during the course of this thing. Apparently, I picked up COVID yesterday, so I'm have a pretty mild case of it, which I'm grateful for, but nonetheless, that may interfere every now and then with my comments here. But let me fire this thing up here, and we'll get going, and away we go. I want to make sure you guys can see that. I think presume we're good to go. Thank you, Roy. So I'm going to a couple of comments just to kick us off. I think keynote's probably a strong word for this. It's probably a rambling set of discourse and observations by me here. And I'm not sure that I'm going to necessarily do the future as sort of point out 2 areas where I think the future is going to be unfolding, where we'll place a fair amount of emphasis going forward here. We have some one concluding side, which I think when you have profound technologies, it's really, really hard to predict, the way it will unfold over time. But why don't we go ahead and get started with these initial set of comments. And this graph is you've all seen, and you perhaps use things that are quite comparable to this. And basically it says, that which we all know is that for decades, frankly, telemedicine, telehealth was, modest at best in terms of its utilization that went on. And obviously with the pandemic and rampant fear on the part of patients and providers about being in the same room together, it took off like a shot. and became quite extensive. Now, it's certainly since then begun to return to Earth, but nonetheless, and I don't think we quite know what the sort of stable new level is, but nonetheless, we've gone through this long phase of, quote, being in the desert to almost overnight, this dramatic increase in now we're kind of funding whatever people call the new normal, for lack of a better word. So the question becomes, well, as we sort of settle into this sort of new reality and new stasis for the use of virtual care, where do we go from here? What does it look like? And I think there's two large areas that we are and we will be and we are spending time on in this industry. One is the term cementing the gains, which if you're with the American Telemedicine Association, as I used to be a couple of years ago as board chair, is sort of taking that which we've learned, the progress that we've made in the use of telehealth during the pandemic and cementing it, making it more permanent and sustainable. There's also, as we'll point out, it's sort of the accelerating the movement to virtual care. And actually, you see this across all industries. One of the more remarkable outcomes of the pandemic has been this acceleration of digital initiatives. But let's start with cementing the gains. And basically, we all know what happened literally overnight. The use took off like a shot. And there was a lot of temporary scaffolding put in place here and these emergency relaxations of rules and regulations, et cetera, all recognizing the crisis nature of what was going on here. And we have to return that to something that's a little bit more sustainable. It's like, having temporary buildings. They're not meant to be for forever. And we have to make sure that as we sort of arrive at a sustainable set, that we recognize the sort of ecosystem nature of technology. So, if you look at the automobile, what does it take for the automobile to be an effective tool? Well, it obviously takes the automobile, but also takes roads and conventions for driving on the roads. It takes gas stations and service stations. It takes driver's license and insurance. It takes a wide variety of factors and activities that have to come together in order for the automobile to be as efficient, as effective, and as safe as we would like it to be. So when we go this list, cementing the gains here, and I apologize for the in the background here, that will disappear shortly here. Well, why don't I go on mute for just a second? So while we cement the gains, there's a couple of areas we need to pay attention to. And work has already started. This is not like something we have to sort of trigger and unleash. It has started. And that is, integrating telehealth into not only the workflow of the practice or the workflow of the ICU or the workflow of the, nursing facility, et cetera, but also into the technology that surrounds it. Similarly, is to make sure we have the right clinical protocols. I mean, there were telehealth sessions or uses of it in clinical care that were not the best sessions, or perhaps the best way to do it in the world, but nonetheless, it was the reality that we all face is the protocols for when is it appropriate, when is it inappropriate to use this. There are clearly this patchwork of federal and state regulations. And those of you who spend time in the industry know that the state is an incredibly powerful actor, perhaps more powerful than the federal government in setting regulations, because states, by and large, regulate the practice of medicine. So states determining licensing requirements and sites of care that might go on, and whether the technology can be synchronous or asynchronous. But nonetheless, there were a lot of regulations that were relaxed, and rather than return to their former form, is to go off and recalibrate them based on what we know and based on what encourages the technology, but also make sure that it is practiced in a safe and effective way. And just continuing the list, there is a series of, what's in it for me? Education, both on the clinicians and the consumers, and a series of studies. And I want to make sure, I've seen this a lot in the HRs, that this aren't the kind of studies that, what's the ROI of a shovel? Oh, for God's sake. The ROI of a shovel depends on, what you're using it for and whether you actually know how to use a shovel here, et cetera. So more important is what value can one get and what did it take to get it? So what management changes, workflow changes, regulation changes, reimbursement changes were necessary in order for us to get the type of utility we need, because leadership will make votes or make decisions based on this about whether they carry it forward or obviously whether to pay for it or invest in it, et cetera. And then last but not least is there's this growing concern, as one of the things the pandemic pointed out was for some striking and appalling, frankly, disparities and inequities in care delivery. If you look at hospitalization rates by race, for example, or death rates by race during the pandemic, it was really quite awful. the disparities, but we could make those worse by having a sort of digital divide where, because people can't get to either the internet or can't afford the device or are not equipped to handle the device, we exacerbate the gap. The point being of this, and I know the American Telemedicine Association and others, a number of you are too, working on cementing these gains, is one set of our future. And it will take several years, frankly, to unfold and make permanent a series of changes across this broad ecosystem that we need to have in place in order for the ongoing use of virtual care to be as effective as it possibly can be. So that's area number one. And an example of that, and this is some work that, again, I don't mean to be a proponent of the ATA, but I am a proponent of the ATA, is work that they have involved in moving the legislature forward. And so as the states, come off their emergencies and go back to revisiting regulations, is to guide them in ways that make sure that those regulations are as effective as they can be. And in some cases, if you can read the colors, is defeating legislation that is adverse to the effective use of this. So you can see the color coordinated map. I'm colorblind, so I have no idea what these colors are, other than to know that progress is being made at a fairly significant level and will continue to be made as we go forward here. Next one here is accelerating the move to virtual care. And a couple of points here. One is when you look, and this is some work that McKinsey published, but has been cited a couple of areas. One of the outcomes of the pandemic was to take existing digital initiatives on the part of across a wide range of industries, across a wide range of geographies, and accelerating. There wasn't necessarily new technology that was going on, but they took plans that were in place and really moved them forward. And you can see by some of the things that they moved them forward by averages of 7 years and 10 years and 6 years. They just accelerated whatever the plans were. And for example, if you're in the grocery business, you might have had a plan that says we want to have people be able to select their groceries and then and arrange for the delivery of those groceries. And that might have been, moving along at a certain pace. Well, that pace certainly got accelerated as a result of this, and similarly in the restaurant business. And it was not just in the outreach to consumers, but also in dealing with the supply chain, which, as you know, took a big hard left and a hard right in terms of disruption to the supply chain. So we will we're likely to see in healthcare a similar acceleration. There's a lot of discussion now. I'm going to go to the Chime meetings in a couple of weeks, and one of the topics amongst the CIOs is this digital front door. The term drives me nuts because it actually assumes there's a physical structure you go to, that you go to a physician office or you go to the hospital where there may not be a physical structure. But that aside, these initiatives, which are designed to reach out to improve the patient experience and improve their ability to manage health, that those got fast forward in lots of ways here. So we will see that kind of acceleration, are seeing that kind of acceleration. And the other thing that is clear is that it covers a broad range. It's more than visit substitution. I used to see you face-to-face, doctor, but now we have a Zoom session, for example. And I think this acceleration will impact three major areas. And I'm sure our panelists will have their own thoughts about, where the impact is. One is shifting the role of the provider. And I'll give you a couple of examples of that. The second, obviously, is that, you could be anywhere and have care delivered, not just within the walls of a physical structure. And the third is people using telehealth or virtual care and doing other things to create pretty novel care delivery models, some brand new business models emerging and new ways to approach the delivery care. And I'll just give a couple of examples of each of these, and then we'll turn over our panels. One, and these sort of center on leveraging the technology to alter the role of physician. In this case, and I don't mean to play up Zip Health, but it's an example, where you can say, I'd like to get contraceptive, or I'm worried about my thinning scalp, and I want to get things that will turn me to looking like Elvis Presley. Whatever it might happen to be, is using this or eyeglasses, et cetera. And in a way, what this does is it changes the role of the physician from being the gatekeeper to the advisor, along the ways as you might want to think about this, because much more of a direct-to-consumer experience that goes on. Not all of healthcare will become a consumer experience in the way that we buy books, but a lot of it might as we go through this. So leveraging the technology to become much more of a direct-to-consumer, but whether it's human beings or artificial intelligence type algorithms, is guiding the person, the consumer, into making an intelligent choice. Another example is where you see this perhaps in mental health, sort of the poster child of all this, is digital therapies. And so rather than me conversing with a therapist or a psychiatrist, I'm actually conversing with a bot and they become pretty darn effective. It's impressive. Not only knowing what you're saying, but knowing whether you're sad or you're angry or you're depressed, but also knowing what part of the world you're from. And so making sure that culturally sensitive comments are brought in place. I think one of the things that's striking me is, how do you know a profound technology? And that's when you relax certain fundamental assumptions. And I think we're seeing that go on here. If we say, look, the archetype used to be the doctor and I were in the same room at the same time having this conversation, et cetera. Now we're saying, well, it doesn't have to be in the same room. It can be anywhere. And it doesn't have to be the same time. It can be asynchronous. And we even relax it further. It says doctor doesn't need to be a human being. It could actually be a bot of some form going on here. So that's a fundamental change to the nature of it, and will probably bring fundamental change to some aspects of virtual care. So the second, and these are familiar examples for all of you who are in this, is the continued evolution of monitoring of health, whether it's continuous glucose monitor. And we're seeing not only advances in telehealth and AI, but also sensor advances, which are really quite striking. The ability to use your pedometer to look at gait and determine whether there's a neurological disorder that's in its early stages, for example, et cetera. Colleague mentioned that they're looking at sensors that might determine if you have ulcerative colitis or Crohn's disease, you're within 30 minutes of a flare. That's a big deal, is to get the heads up and warning that something is about to happen, that you may want to be nearer to a facility than you are currently. Another example is, again, this is sort of not just the IT stuff, but it's the testing. My COVID-19 test, I had the second band, which is unfortunate for me, but nonetheless, between this and cancer care or colon cancer screening and a variety of other things, is the ability to conduct testing at home. And the last example, and I don't mean to be the proponent of medically home, but as you're aware, is the idea of perhaps we could spend some portion of your stay at home rather than the hospital, and also continue to receive terrific care. Virtual care is essential to that, but as those of you who spend any time in this area know, it's a logistics problem, big time. How do I get the supplies, the equipment, the nursing staff to your home and when you need it, in a manner that you need it? Point being is, we're seeing this explosion of very diverse efforts to move the care outside the traditional walls into me walking around or you being at home, et cetera. The third is new business models or new novel ways. So one of the things you see is with virtual care center is targeting primary care and other types of care for very specialized communities. So the LGBTQ community, for example, but there are others where people are going after, for example, Medicaid only, or particularly ethnic groups, for example, is using that. And then the last example is what kind of striking is Amazon, which, as you know, was in the virtual care business. Christy made comment on that because she spent some time with that, but recently bought One Medical. And it's not only the business model of getting into novel care delivery approaches, but if you know Amazon, they make a lot more money off Prime users than non-Prime users. So this just adds to the value of being a Prime user, and hence increases the likelihood of loyalty to Amazon. So the revenue might be in areas much more diverse than simply receiving your care. So the point being is that organizations will use this. Now, last comment here. One of the things you see when people study profound technologies and their impact, and this could be flight, this could be refrigeration, this could be the railroad, et cetera, is one of the things they see is that technologies often begin with a substitution effect, and that leads to what we call second and third order. So here's an example. Early 19th century, and there's the automobile, and it was fundamentally a substitute for the animal in the back, that we wouldn't need horses anymore. We're substitutes, capital labor substitution, fundamentally is what it was. Now, what they didn't realize, and nobody had the ability to see, is where it would lead to the second, third order effects. It would lead to the creation of suburbs. That's not what people envisioned in 1900s, that you could now be 20 miles away from downtown and get to your work on time, et cetera, and expand the geographic footprint in a metropolitan area. Similarly, when the printing press was invented, it was a capital labor rather than a bunch of monks in quills and press. It made it a lot more efficient. And the result was explosion in the knowledge base of the world. And in this case, the ability to publish and distribute common sense, which you may recall Thomas Paine wrote as part of the, inciting the rebels in the American Revolution, et cetera. So I think what we will see in this future, a couple things. One is there's sort of dramatic changes coming, but they're also very difficult to foresee, no more so than Gutenberg could foresee or Henry Ford could foresee what they had unleashed when they began their sort of novel interventions and et cetera. So that's it. that's all that I have to contribute. And I appreciate your being patient here, because you say, I hope, thank God it was short, so we can get on to the people who actually know what's going on here. And so we're going to go in rank order, and I'm going to shut down this screen here and turn it over to my colleagues for some additional comments. And Ativ, we will start with you, and we'll take it from there. So Ativ, you're on.
Well, thanks so much, John. So sorry to hear about COVID. I hope you recover quickly. And thanks for joining, even despite feeling ill. In speaking about telehealth, I thought I'd start with both the first and the last slides that John had. First showing the very rapid rise, and then a very dramatic drop, 60 to 70% off. If we don't include behavioral health visits, the drop has been even greater. And this uncertainty, as John described, in terms of the second and third order, where we're headed from here. But I guess I want to first start with what the heck happened here. And I want to remind myself, for those of you who were engaged in telehealth prior to the pandemic, at least many of the conversations I had with telehealth proponents was that this is an amazing way to deliver care. And we just got to convince the patients and the doctors, just try it. Come on, just get it in there. You'll love it. You'll love it. And they would love it and they would embrace it. And obviously that didn't happen. We went in the opposite direction. They all tried it and they're now back to in-person visits largely. As one of my colleagues who has been a big telehealth proponent for a long time said in a moment of frustration, just the great telehealth experiment has failed. He was frustrated that I don't think that's where we are right now, but I want to at least acknowledge that this was not what a lot of folks had expected. And I think it's upon us to reflect on why that's the case. Why did visits go away, telehealth go way up and then go way down? Not back to baseline, I recognize that. Some of it, as John alluded, first of it, some of it's resistance to change. Doctors we kind of are stuck in our ways and we like to do things. And maybe that's possibly, you've been doing it for 20 years, you kind of want to go back. And I think that probably plays some substantial role. And then as John alluded to, another aspect of this is uncertainty. Providers have gone through a period of substantial financial uncertainty. They don't know where the heck the reimbursement and the regulations are going. There's so much uncertainty and then people are like, retrenching, I'm going to go back to what I know. But I think we also, besides blaming, resistance to change, uncertainty, we also have to acknowledge that in many circumstances, they weren't satisfied, patients and providers. In some national surveys that we have done, patients and providers generally say, yeah, this was great. Thanks so much. This was awesome to have this capacity to treat patients during the pandemic. We wouldn't have been able to get by without it. But then when we ask them, what do you want to do afterwards? They're like, oh, we want to go back to in-person visits. And the fundamental issue is that, and we can argue whether there is right or wrong, but the patients and the providers aren't sure this is really up to par in terms of the quality of care that's being provided. And I think that's evidenced by the fact that in many cases, they're going back to in-person visits. Certainly, that doesn't deny that there's a lot of stuff that you can do without a physical exam or testing, just via what we're doing right now. But there's a lot of stuff that can't. And I think sometimes I get frustrated by the myth that a video encounter is sufficient for almost everything. I think it's probably enough for a minority of the cases. And that in 2022, modern medicine means you need to have physical exam in some cases, you need testing, you need EKGs, and you need other stuff. And if we are really going to have this resurgence in the growth of telehealth, how do we address this issue that patients and providers don't feel it's up to par? And is it that we need to start, and there's a whole industry developing around this, about bringing vital signs, equipment, testing, other things to the home or to work sites or to other stores or other places so that we can add those other elements of an in-person visit to a telehealth visit. So that's one key thing that I wanted to emphasize on this. Now, the second thing I wanted to focus on was a distinction that I hear from, I'm a health policy wonk. And so I talk to policymakers a lot of time, and they are really making a distinction between telemedicine delivered by brick and mortar providers, primary care docs, existing cardiologists, et cetera, and telemedicine only companies. When I showed you that, when John showed that up and then that down, that's mostly brick and mortar providers, because right now telemedicine only providers make up a pretty small fraction of the business, but they're growing. And as anyone is aware in this space, it is just unbelievable how many different companies exist out there for telehealth only for whatever condition you have under the sun. And they're getting tremendous VC and other investment into their growth. And so that share of the pie is growing. And I want to acknowledge, and as John had mentioned, the tremendous potential that these companies have that really go beyond clinical models that focus on visits and really change the way, and I think some of the other panelists will touch upon this later, have enormous potential to change the way and improve the way, rethink how we manage, say, hypertension or another problem. But I also want to acknowledge the tremendous leeriness from policymakers about these companies. They see all this investment. They see the need to grow almost at any cost. They see examples of potential bad behavior by some of these companies, a minority, but they're focused on those companies. And they see that their valuations, they say that all these companies want to become the next healthcare unicorn, the company that's with $1 billion valuation. And they know who the heck's going to pay for that? Taxpayers and payers. And so they're a little bit leery of being the funding source for these unicorns. And so my sense is that as we move forward, we're going to see policy move where we start distinguishing, appropriately or not appropriately, between these sets. The providers we like, the primary care docs, the brick and mortar, and the ones that we're a little bit leery of, these telemedicine only companies. Through different regulatory structures, Medicare might introduce new ways of introducing those companies as providers, requiring in-person visits on some frequency so they can keep those providers in check. Again, and I hope the other panelists touch upon whether this is a good idea or a bad idea, but I wanted to make sure that this issue was brought up in our conversation. And lastly, the third thing I thought I'd highlight on, and again, building off of John's thoughts, which is specifically related to the issues of equity. And a lot of that conversation comes around phone visits. Let's acknowledge we had this enormous and very successful rebranding. For decades and decades, doctors have called patients. Here's your lab test, what should you do? And that was done for free. And we rebranded all those phone visits and called them audio-only telemedicine visits and started paying for them. And frequently at the same rate as an in-person visit. We don't know. We've been doing some work on this, trying to estimate what fraction of all that telemedicine that John showed is phone visits. And I don't think we have good data on that. Claims are useless in this regard. And some of the surveys and other things are a little bit, but my rough estimate is about 30 to 50% or even more possibly of all those telemedicine visits were phone calls. And the key question that I hear a lot about is what do we do about them moving forward? And the key issue here is that due to the digital divide, as we mentioned before, many patients, unclear how many, can't access a video visit. And there is the hope that these phone visits are the only way type of telemedicine they can use. However, I think there are appropriate concerns that these telephone visits are prone to overuse and unclear on the quality of care that's being provided by them. And we have the potential fear that we create a two-tiered system, that the rich get video visits and the poor get phone calls. And so we also are looking for policies and levers to try to address these issues. And I suspect other payers and others might start following Medicare's lead, that they're sort of going down this pathway, which is saying, okay, we'll cover the phone visits, but only under some exceptions. You need to offer the video visit and the patient has to tell you no, or something along those lines as a verification step. Because again, there is a desire to have these as part of what we offer to patients, but also a concern that we don't want too much of these phone visits. So 3 ideas. Why have telemedicine visits fallen so much? Do we distinguish between these telemedicine only companies and brick and mortar providers and how telehealth is used. And lastly, the issue of phone visits are three things that I hope we can continue in the Q&A to discuss and debate. So I think, actually, John, I can't remember who goes next.
I know who goes next. It's Chrissy Vanetti. That's terrific. So thank you. And I don't doubt for a second that you will have spurred some questions and some commentary. But in the meantime, feel free to enter those into chat if you'd like to do that. Chrissy, let's put you on stage, and it's all yours.
Okay, great. First, thank you, John and Yuri and DCI Network for having me at the end. But just for context, I've been working in telehealth for about 25 years. So it's very interesting to look back and reflect on where we've been, where we're going, and really the future potential. But during that time, it's been exposure to telehealth from an academic medical center, a national nonprofit health system, big tech with Amazon and Amazon Care, as John mentioned, and now with United Health Group, which is a combination of United Healthcare, our payer side, and our care delivery side, Optum. And so I currently run Optum Every Care, which is a 50-state virtual medical group, and then community walk-in clinics, as well as employer on-site clinics as well. So really this omni-channel ability to use technology in a unique way. But when you combine that, we have with our Optum assets of Optum RX and Optum clinics, primary care, urgent care, even things like behavioral and advocacy, we have a real potential to make a difference and redesign the healthcare delivery model. So excited to bring that perspective. And there's really three areas that I want to focus on today in my comments. And some of those will build off of what Ativ just shared as well. But, you know, the volume peak and then now coming back to earth, as John described it, I don't think we should be surprised by that. I mean, during the pandemic, there was not a choice. And so I don't want people to interpret that of it was just a solution for the pandemic. If you look at the projections of volume, where the volume should have been for telehealth visits in 2020, it was projected to be 3.6 million, and we hit 120 million visits. But if the pandemic had not happened, we're still much higher than we would have been at this time if we continued on the same trajectory. So I don't want people to over-index on the meaning of what that is. If we think about it from a real example, during the pandemic, if you went to get healthcare, whether you called in to schedule a visit or you drove up to the clinic, you were offered a virtual visit. And today, if you call to schedule an appointment or drive to a clinic, you're offered an in-person visit. The two are not really combined in a way where we can realize the full potential. And we've got a lot of work to do. And I say this in almost every presentation, because the hard work is still to come around changing and redesigning the operating model of healthcare so that the two can coexist. We're leaving a lot of abrasion and friction at the decision-making point of patients to decide if it's right or not and can it meet my needs. And so they're going to fall back to where they know their needs can be met. And then if providers aren't sure, and there's an abrasion there, if they can get reimbursed or if they have the right technology to know if the patient is in the state where they're licensed, all of those types of things are abrasion points that cause us to go back to the easy road, which is what we know, go back to the standard model. And so the operational redesign and the rules engine and intelligence that's needed to be able to allow the two models to coexist so that people can get care where they prefer, and where it will meet their needs is the work to be done. So I'm really excited about what we have to do, but it's going to be hard. And so we have to push forward in that space. The other area I thought I would touch on, because this is starting to emerge, are the virtual first health plans. So several insurance companies have put out new virtual first health plans, and they're really early. So it's yet to be seen the outcomes of that. But what's exciting about it is it now brings in affordability into the play. It's one thing to change the site of care using telehealth. It's another to change the impact of out-of-pocket cost and total cost of care. And so in these, the patient starts virtual And it doesn't mean it's virtual only, but they have to start virtual first, and then they go to in-person care if it's needed and necessary. So with that redesign and change in health plan design, there's in many of those, there are 15 to 20% lower premiums. And so exciting to see where those go. I don't think any of them have been operating a full year yet. So something to keep your eye on and watch, because it's really bringing a new care delivery model with incentives and affordability. The other area I thought I'd touch on, and Atif, you mentioned it as well as John, talking about all the just huge growth in these, what I call programmatic digital health offerings and companies. So whether it is for a population, women's health, LGBTQ, or a condition, GI, MSK, whatever, diabetes, those are just growing rapidly. And the area that I wanted to highlight in this is that healthcare is a team sport. We need a lot of us to be able to actually improve the outcomes of health. But the risk of these, what I would consider point solutions, are that we fragment an individual into conditions or aspects of them that aren't coordinated. And so we've got to work really hard to make sure treatment plans are coordinated so that we don't have duplication of testing or things that aren't in sync with each other. And so there's a lot of potential there, but one where we have a lot of responsibility to be able to coordinate around a whole person mentality, so that doesn't become fragmentation and ineffective and more costly. So I guess the 3 points then that I'd just kind of wrap it up with, and hope we'll have more conversation about this, is that we're at the beginning of the game. We've got a lot of work to do to integrate virtual and in-person care together and to create really an omni-channel experience. Not necessarily any one door is the right way to come in. You hear people talking about a digital front door. I don't care what door you come in, just come in and let us help you get well. So we've got a lot of work to where that actually can be realized. Virtual first plans are early, but incredibly exciting to see where that'll go. And then lastly, for programmatic digital health companies to really be able to make an impact, there's got to be a coordination across the different efforts around to focus on whole person care. So excited to see how digital will work across that entire continuum, from the minute somebody thinks about getting care to getting care and ongoing management. So a lot of potential there. But thank you for letting me share my thoughts.
Nicely done, Christy. It's thoughtful as always. Quick comment before, Amar, we go to you. When I was a CIO and sitting with my leadership team and we listened to a discussion about a topic, I'd always say there are 3 things. And I said, if you say there's one thing, you didn't understand the problem well enough. It's more complicated than that. And if you said 5 things, you just overwhelmed our ability to execute it. We're going to screw it up. So no more than 3, because that's about the capability of any senior management team. So I don't know, Amar and Roy, whether you'll continue the threesome, but Amar, I'll put you on and look forward to your thoughts.
Thank you very much. In order to think about how telemedicine is going to evolve, it would be good to do a comparison with another industry which has somewhat similar characteristics. And I'm going to make a comparison with the financial industry because both have large amount of data, both the timing is important, the confidentiality improve, and it involves a lot of people. So just as we're dealing with healthcare in the financial industry, a bank in the US was only allowed to operate in one state of the country. Citibank in New York operated, Bank of America operated in San Francisco. And anytime, the first thing we threw it off was the introduction of bank checks. And when checks were introduced to go out of state, the federal government said, we will take responsibility for clearing a check which is out of state. So for a few years, I spent my summers in Arizona, my winters in Arizona, my summers at MIT. If I gave a check written on a Boston checkbook to a dealer in Arizona, in Tucson, the dealer would give it to the bank, and the bank it would be read by human eyes. Then it would go on a truck to the nearest branch of the Federal Reserve Board, which happens to be in Sacramento, California. Then it would go by an air courier to Boston, then to the lead bank, then to the local bank, and then the check would be given back to me at my address, which was designated. It cost $1.25 to society to read that check and process it, and 44 billion checks were processed in this manner every year. So our group designed the technology for being able to read that check automatically and be able to transmit it electronically, but there was widespread resistance. People did not want to lose the money. There was an entrenched business. And the thing that made it all work was 9/11. As soon as 9/11 took place, all the planes were grounded. The traditional method could not be used. the federal government immediately said that the image of the check should be used. And that's what played a revolution. And that broke down the barriers between the states. It broke down the barriers at the international level as well. So, and then we try to do the same thing in the area of medicine. We designed something for mammography, an automated system. Nobody would use it because immediately the reimbursement thing came in. And I said, wait for the next crisis to come in. When the next crisis comes in, everything of this will be taken care of. And that is just what tells us that what drives sometimes a crisis, the best catalyst which is there. So in the financial industry, we also see a lot of business being done across state boundaries now, across national boundaries now. And about 10 years ago, I'd written the first paper advocating both these things. I'd written a paper saying that all the regulations prohibiting or putting restrictions on interstate practice of telemedicine, they violate the interstate commerce clause of the US Constitution, and therefore these laws are illegal and inapplicable because they're unconstitutional. And 7 years later, that law was given a lot of attention by Department of Veterans Affairs and by others, and it's been largely accepted as far as the regulations are concerned. And on an international business, they said that people make more mistakes at night when they're sleepy. So we should have a system of telemedicine by which people work from abroad during daytime there in order to practice medicine at night in the US. Again, I got a lot of hate mail, but today we have Emory University, for example, has posted some of its doctors and nurses in Australia. They work in daytime there to look after patients at night. So we are seeing this evolution of telemedicine take place both across national boundaries as well as across state boundaries. And we still are constrained by the traditional system. We did a survey of all the state medical boards, how they responded to telemedicine, what standards they're using. And it appears in the latest issue of the journal Telehealth and Medicine Today. You can have a look at it. It's a very dismal state of affairs, what is going on. Very few states have recognized it. Getting any information about people doing something in one state and practicing in another. We came across a case where a person has been disbarred from service in 3 states of the US and is practicing in a 4th state and running a telemedicine company in the 4th state. So on the quality side, we think a lot of things has to be done to ensure the safety and quality of treatment which is given. And this reminds me of an anecdote from 9/11. After 9/11, they made it a point that the pilot's door would be closed, locked in flight, and only the pilot and co-pilot will have the keys to it. So there's a case where the pilot went to the restroom and the co-pilot locked it from inside, and he actually crashed this Lufthansa plane with 120 people on board. He had mental problems, but again, because of privacy rights, that thing was not known. So again, there's a lot more potential now to do it, and therefore we need new methods in order to guard against these kinds of things. We need to find better mechanisms of doing it, and we also need to think of better mechanisms both at the state level as well as national level. In other countries, we find much more telemedicine being done across national level. Here it is very little, and there are cases in which I've actually made examples. When I was in Arizona, 2 of my students, they got burnt in the kitchen, and they were taken to an emergency room. They were given a painkiller 4 hours later, and they were treated 16 hours later from that incident. Across the border on the Mexico side, there was a private hospital where the waiting time in an emergency room was 10 minutes or less. There one nurse for every 2 patients. There 1 doctor for every 2 patients. So using telemedicine in situations where we still have a very aggravated situation like ER rooms, for example, could be one solution to it, and having them not necessarily within the country, abroad also may be another way to do it, just as Emory University has done. So those are some of the things that I see will happen on the thing. In the state and medical board survey, very few states were willing to give us any information. They don't want to reveal anything which is there. One state said under the Freedom of Information Act of that state, they cannot release any information to outside the state. It's very, very difficult to find any information about doctors. And a new system is being designed to have quality control at the national level, but it's again connected to the state licensing boards, and many of the records, they are redacted, and you cannot find those records of these doctors. So we are getting into an area which is a little that demands attention and unified action on it. The second thing I wanted to say is that just as we have this problem of national and state barriers to telemedicine, we also have organizational barriers. Systems which do not allow information to readily go from one system to another. In the Boston area, we have a number of medical chains. If you get a test done at one center and you go to another of a facility of another one, it's not that information is immediately available. It takes a lot of time and effort. And with telemedicine, I find this problem is getting even more acute, because if you use the minute room of CVS or use other things, all these records are all being split across. They are all fragmented at this point. And again, just as we are expecting the government to go ahead and do some things on state and federal regulations, we need more organizational cooperation in this manner, so that this records which are from telemedicine environment can actually be sent from one place to another, and they all get an integrated view, and there's not repetition of tests which has to be done in this mode. We also see this need emerge further in the case of remote patient monitoring, which is another aspect of telemedicine. When we have remote patient monitoring taking place, currently these records are all captive to a particular environment. It's difficult to access them. It's difficult to get into a system. Again, it's very few people who will only see doctors from one particular system or one particular organization. People tend to use doctors across chains, across groups. That fragmentation is much more intense as a problem here than in some of the other countries that I've visited and seen, in terms of regulations, in terms of the sharing of information, in terms of the transmission of information which takes place. We also have problems of missing and conflicting data. We have situations in which the machine will take the reading and the nurse will also come and take a reading, for example. And if those two readings are different, generally the convention is that the human being is supposed to take the correct reading, and that reading normally overrides the machine generated reading. We have come up situations at a particular hospital chain where we got data from them that the times in which the difference was the maximum was actually the cases in which the patient actually died. The disparity between the human taken readings and the machine taken readings. So again, more research is needed in these areas of how to deal with issues of missing and conflicting data. We also have the other problem, the problem of information glut. Many doctors and medical personnel are complaining that so much data is available now. How do we deal with it? In emergency, we need to do it. And I remember years ago, I was working and advising the Air Force on how to integrate information from Army, Air Force, and Navy, and wrote papers on it, wrote a book on that subject. And a general of the Air Force was saying that if an emergency is there, like a pilot is going on a bombing mission, we want that pilot to have the minimum amount of information. Contrast this to the situation in the surgery room here or in the medicine case here. In an emergency, we have so much flood of information that it takes a long time to really go through that information. So we need better tools to do it. And with telemedicine, this thing will become even more aggravated as we'll have more and more data coming in. Finally, we have to deal with this issue of disparities in medicine, and especially in telemedicine. This issue was mentioned a little briefly. We have done a survey recently using fairly advanced tools, and which we came to the conclusion that in granting prescriptions for opiates, there was very clear discrimination which was taking place. For the same symptoms, a white patient was more likely to be given a prescription for an opiate than a colored person or a woman. And we found that the disparity was not just in the numbers, it was also in the text. That when the nurse was writing the notes, the nurse was saying this person is a very cordial person, very easy to get along, or this patient was a confrontational patient. And these notes, in a sense, also bias the opinion of the doctor in terms of whether to give a prescription for the opiate or not. So these new things are coming up, which we need to really think about it in a balanced way of what can be done or what should be done in these areas. There is, as we have this issue of nationalization and globalization, we are faced with the issue that when new devices come in, new methods come in, who should regulate it, how they should be processed. On one side, as I said, that there's not enough regulation which is taking place to ensure the quality of it. On the other side, different countries, different jurisdictions are trying to take claim responsibility that you have to get it also approved in our jurisdiction. We need some standardization taking place, and for different industries. For example, in the case of internet, the organization which did a lot of this standardization was the World Wide Web. It's not a government organization, it's not a private one. It was anchored at MIT for a number of years. Now it's been spun off. In this case, who should be the agency looking at this standardization of it, the quality control measures of it? We don't have anything at the national level at this point. We don't have anything at the international level at this point. This is an area where industry, academia, governments should probably work together. And this really needs to given more attention if we want to do it on a global basis. We all travel a lot today. We travel across national boundaries. And the European countries at one point had a lot of rules disallowing patients' information to be going. They now notice that 20% of the people in Europe go from one country to another. They've made it more easier for records to be shared. They've made it more easier for inter-country telemedicine to take place. So these are some of the thoughts which I think will characterize how this industry is going to evolve in the coming years. Thank you very much.
Thanks, Noor. I very much appreciate the comments. And I've always thought it's a challenge, having spent a year in DC as a regulator, of when and how do you regulate when it's so fluid and so early, because you can over-regulate and crush things that you really didn't want to. You can also allow certain things to go on where you say, I really do need to intervene because there's safety or fraud issue or whatever it happens to be. Anyway, Roy, why don't you bring us home, big guy? Give us some thoughts, and look, you're on.
Sure, terrific. So I'd probably be able to give you some time back because so many important, points I was going to make were made by others. So I can be a little bit more brief. And it always pains me, John, to go after you because there's always humor in the way that you present such important points. I wrote down what is the ROI of a shovel, and I will plagiarize this in future conversations. Knowing that Ativ, is going to be on the panel and different opinions are going to be shown, I kind of did a little bit of an experiment, earlier this morning, walking into it. And I did the equivalent of tossing a coin on the map of the US. And today, technology systems are smart enough to say, okay, let's see what happened under that geographical area that's covered by that coin. And I took 3 points in time. Please, this is not a scientific experiment in any way, but I just kind of queried our servers to say, what happened in telehealth under that coin? And, to prevent variation, I said, let's take this week, just this week in October, and looked at what amount of telehealth traffic we have seen in October 2019, which is arguably long before COVID. And under that coin, we saw 20,000 patient encounters in that week, pre-COVID. And then we said, let's look at what happened in peak COVID. And we saw a huge jump, exactly what you showed, John, where under that coin, there were 100,000 patient encounters in that week, in that geography. But then the funny thing was, we said, okay, what's happening under that coin last week, 2022? And the funny thing is that the number went up to 130,000 under the same geographical area for the same week in October, for essentially the same population, the same coverage of payers and health systems, that we run in that geography. So one thing that is, and maybe the number is not important, but rather the fact that the number of telehealth encounters happening under that coin has risen now from where it was in arguably peak COVID period. Now, I don't think that this is applicable everywhere, but one thing that is becoming pretty certain is that telehealth is a little bit of a too broad of a term at this point to describe the kind of things that people are doing with technology. It's not one of the same as it used to be prior to COVID. It is also not just about access anymore. Prior to COVID, we all talked about telehealth as an access mechanism. I think people are doing, completely different things with it today. And we've definitely, in the shovel approach, I would say we have definitely not reached the end of the internet yet. We're not closing down online healthcare because of the variation in numbers. And probably, if you kind of lift that coin and look at why are people talking about places where it is declining or significantly less than COVID, and in other places it seems to be, growing more and more and more as we see it, is because I think there's been a change in the way that the volumes of telehealth are running. It used to be that telehealth was primarily something that patients would acquire. Patients would be proactively logging in somewhere or downloading an app and installing and registering, and it was mostly around urgent care or behavioral health under certain circumstances. And when we look and we pry into those growing volumes, we actually see that flavor of telehealth in many ways have kind of allowed or moved to the second place in terms of volume. And telehealth that is actually clinician prescribed not patient acquired, is by far the biggest volume generator that we see around the country. And clinician prescribed is follow-up care, and clinician prescribed is where you have a relationship with that clinician. And by the way, I think this is all video, but I'm sure the same goes for telephonic. I don't think that the modality is that dramatically different, but it is a very different animal of telehealth, as we like to call it. And interestingly enough, I think it is growing, that's just my opinion, because clinician prescribed telehealth is much more in line with how we experience traditional healthcare. We usually are followed by our physicians, or clinicians, I should say. And they tell us when we need to have a follow-up and when we need to come back. And even more experientially, I think that as patients, we like to be cared for. We don't necessarily want to be the empowered patient that is the one reading all the books and figuring out where to go to acquire the services. So this model of telehealth that is clinician prescribed has really skyrocketed to become the driver of the volumes of telehealth that we see continue to grow, even though hopefully, with the exception of John, COVID is in the rearview mirror. The second point that I want to make is that it really is also a change in purpose. A lot of people are still thinking of telehealth as a way to do the same thing that we used to do in the doctor office through technology. And arguably, if you kind of take the online retail world or whatever it is, there was a period of time, some of us are old enough to remember, where people would say, why would I buy online something that I can buy in a store? I was part of that generation. I think a lot of us were in that generation. And of course, we know that that has changed dramatically. And I think that what we are seeing in front of us right now is that people are going beyond of saying telehealth is a change in place of service to really a whole new world, blue ocean of opportunities of reimagining from the ground up how we're surrounding patients, how we're imagining care. And it comes in different flavors. There's a lot of those that, everybody here on the panel can mention, but on the provider world, we see a lot of application of telehealth to do a better job helping clinicians see patients, and probably driving this, also a byproduct of COVID, is the workforce attrition, which is a terrible reality for a lot of different health systems. Key to that is the introduction of care automation. And John, you mentioned the fact that what was opened in COVID is the receptivity of everybody to the fact that some part of your healthcare experience will happen through technology, whether it's on your phone. But the moment that you do that, maybe there's a bot, maybe there is an NLP, maybe there is a machine learning device that speaks to you. Care automation became kosher. It is okay to talk about it, and it has tremendous powers to change the way, the reality of clinicians, and we are spending a lot of time and effort in doing so. On the payer side, arguably the other big leg of the healthcare industry, and Christy talked about it, the model of virtual primary care, the saying maybe we can rethink what is the first point of arrival of patient to begin to consume the healthcare that they need. Maybe that can actually happen over technology. And it's not about access, it is convenience to patients, but most importantly, it means that if care happens on the digital platform, we have the opportunity to put primarily in front of the clinician a lot of the analytics that were looking for purpose all these years. Suddenly they can be injected into the scene of the crime, right between the eyeballs of the patient and the clinician, to influence the care that's being delivered for the better quality, better referrals, better medications, better formularies, and so on. And I think both the provider side and the patient and the payer side are really thinking about how will that change the experience of healthcare altogether. The last point, brief point that I just want to make is that, and again, John, with the printer example and the car example, you kind of nailed that point. We have to start thinking about it more as what is going to be the downstream ripple effect, not just how you're going to get urgent care or follow-up care. And there are some fundamentals that need to happen. People have already mentioned the notion of state licensure. We just have to accept the fact that the internet does not stop at the state line. It's just the reality, but also that there are opportunities for us to reimagine care models Like, for example, could it be possible for a PCP in North Dakota who has a cancer patient to bring in an oncologist from Dana-Farber to help them locally care for the patient that has cancer in North Dakota because they specialize in the delivery of that care? There's a lot of egos involved. There's a lot of payments involved, issues, but that's drama. So finally, I would say, look, I think telehealth isn't video conferencing. It really is more of a logistical infrastructure for the distribution of healthcare, just like Amazon has done for retail. And just like Amazon did, it really didn't just change where we buy stuff, it changed how we buy stuff. It changed how frequently we buy stuff. It changed our brand affiliation. It changed the amount of stuff that we buy. And that is the unstoppable effect of this logistical infrastructure, which time will tell how far it will go and how quickly. I'll just stop there.
Excellent, Ryan. Excellent, all of you. I mean, a couple of quick comments reflecting a number of comments you all made, and then we'll open it up either for panelists asking questions of other or the audience overall. I think a couple of things. One is we've got to be really careful about the count thing. You know, how many happened, how many didn't happen, et cetera. I mean, it can get in the way here. So for example, if you look at the height of the pandemic, what percent of revenue, retail revenue, was done through e-commerce versus in the store, height of the pandemic? And the answer is 18%. You say, that's it? You know, Amazon, all this kind of other stuff, people afraid to go outside, 18%. And you might say, that's not much. Well, you don't realize how industries were destroyed or made or created by a small number. So even relatively modest numbers can really change the world in very, very big ways. I think the second point is, and I've heard this, and you guys are all good, is to avoid the shiny object syndrome of getting all wrapped up about the technology, whether it's this or that. And I get it, the technology matters, et cetera. But I used to teach a course in e-health at Wharton, the MBAs. And I remember one of my students, and they're all starting companies, they're going to be the next American Well, Amwell. That's what they want to be. They want to be Roy Schoenberg, for example, and Ito. He did this company that said, we're going to wire up middle-aged men who had a cardiovascular event to help them do the rehab, because they're usually not very good at it, et cetera. And so we're wiring them up and we're communicating data, and it's really cool. And I said, well, how did it work? And he said, it worked, but the most important thing about whether the guy actually followed his rehab was the degree to which he felt that the care team cared about him. So interesting. It wasn't the technology, it was the messages that came back, says, way to go, John, you know, losing your weight, or you're doing your exercise, or geez, we're worried about you. So just remembering how, you know, human this whole thing is. I mean, care is a real word, and it has real meaning, et cetera. And then the last point, and then I will be quiet, et cetera, is I think, you know, we have to be careful too about this focus, and it's right and wrong, on the visit substitution. I mean, I get it. I mean, at the end of the day, it's what drove it in the pandemic, et cetera. What that can cause is blindness to the sheer array of what is going on out there. I mean, between the, you know, remote patient monitoring and the new business models, et cetera, you get all tangled up about whether this, that, or the other. And it's not wrong. It's just not broad enough. That's got to go on here. And the real exciting stuff will be the new businesses and the new uses, et cetera. The others, I do think, and it's like, you know, in order to become an adult, you got to go through adolescence. At least that's the theory, is that in some ways you have to go through the substitution stage to get to the really interesting stage. You got to get that behind you, and you got to get that foundation laid down and deal with some of the issues. And then you're in a position to really think about what's broad and what's going to cover. So I'm going to stop there. And let me just, first of all, see if the panelists have any additional comments or reactions they'd like to make. And then Yuri, I know you've done a great job of watching this chat session, and maybe we can surface some of the questions that have come up. The panelists, any comments or questions of each other's stuff, other than I know you have unbelievable admiration, you're stunned by the brilliance of your colleagues. I'm going to turn it over to you. I'm sure if there's stuff occurs, then they will do that. But why don't you pick a couple out of the chat session, and we'll see what our panelists think.
Sure. So thank you so much, all of you, for tremendous insights. So yeah, I was struck by it, some of the questions deal with this as well, as sort of the perceived value. So, you know, I think we could be really fixed about the number, but it's really what's actually happening in those visits and where it brings value in. I'm wondering if you could all comment about how we can sort of better communicate what the benefit is of telemedicine, because perhaps maybe not only the patients and the providers don't quite understand the value, but maybe some of the legislatures who create the rules that affect telemedicine don't understand the value. Maybe they're so fixated on just the number, but not about what is actually happening. And you know, this opens up not just for urgent visits and telemedicine, but could open the door to decentralized trials, better follow-up care. We have millions of people with long COVID, and maybe this could drive efficiencies that are both financial inefficiencies, but also maybe more timely care. So how would you characterize where we are in the perception of value of telehealth and telemedicine? And Roy mentioned that there's different types of telehealth care. It's not just, maybe people are fixated on just the video consults, right? But there's different forms of this. So how do we communicate better the value, and where are we on that value proposition? And just thinking about, in terms of some of the slides that you did, John, you know, the iPhone wasn't the first smartphone, but it changed the patient experience and created the opportunity for apps that revolutionized. So maybe we're in the early innings of this. So let's open up to the panel to comment on some of these themes.
So Roy, why don't we start with you, and then any other panelists who care to comment? Because presumably you deal with this all the time.
Yeah, I mean, the interesting thing is that, you know, 15 years ago, when we were trying to promote telehealth, everybody came in and said, to buy, you have to show us the ROI, the shovel, right? I mean, that reality. And at the time, you know, we were lucky to have good friends at Anthem and United and Avera and other places that did, you know, Optum, that did a couple of studies that showed the value, the financial ROI of urgent care, which, by the way, interestingly, all of these different studies ended up at about $210 that are saved for a pair when one of their members utilizes urgent care. I think the world has changed. I think people are now no longer asking even for the ROI, because they understand that it's you know, it's really a matter of perspective. But I would argue, in the spirit of kind of trying to keep everybody awake, you know, postprandial after lunch, I would say, what is the value of a clinician visit, of seeing a doctor? Because, you know, I don't think there was a study on that, frankly. But I would say that when you start thinking about the value of telehealth or these technologies separate from the vast difference of value of one clinician visit from another, you're trying to kind of hang on the technology elements of value that have nothing to do with it. The same clinician visit for a patient that doesn't have a lot of healthcare and could now get in front of a clinician through technology for the same exact visit is drastically different than the value for that same encounter for a patient that happens to live in downtown Boston and can walk over to MGH. We are the value of telehealth that surround an elderly patient who is in their home, that without telehealth wouldn't be seen, and therefore we would not detect early deterioration in their condition. How we surround those patients has a huge implication on the value of that one transaction. I think that, and I'll just say this, I'm happy that Congress didn't have to vote on what is the value of the embrace of email. Because the national budget, you know, the Congressional Budget Office would spend 5 years trying to understand what the value of this. Telehealth is a distribution system. It is the value of the original goods delivered in a different way. It doesn't have a value on its own. That's what I would say.
See, why don't you comment? Because you obviously deal with this too.
Yeah, I wanted to build off that. I couldn't agree more. And the way I've been approaching it, because I have to get investments for my own company to be able to do this, and you know, and tell the ROI on it. But to me, it's around what's the difference in the value of a digitally enabled system of care versus one that's not digitally enabled. And that goes across, like, how does that help us manage our labor? How does that help us reach more people or have better outcomes and achieve that with less overhead? I mean, there's a lot of different ways to look at it. And I think that's what's been really hard. Tracking the dollar and really understanding it has been a challenge that we've all been kind of battling for years, as the CBO tried to look at our statements around value and didn't necessarily believe it, and then that impacted our ability to change reimbursement. But what we know is the old system does not work. It doesn't work. So this new model of a digitally enabled system, I think that as we've got more and more risk populations that are fully managed and are now within a system that has digital tools being used all the way from the moment somebody thinks about care to ongoing remote monitoring, that's where we're going to really be able to demonstrate the power of that. So I think it's really just a reiteration of, and a different lens of what Roy said, but it's really about a digitally enabled system of care and not a video visit.
Well, Steve, AG, Amar, but then we're going to any other additions you'd like to add?
Make one point that a little bit of frustration from my end about the demonstration of value. I get that this model can have tremendous potential impact, and all these companies out there, there's probably some companies that are really going to change the world. However, we know that for most startups in the world, most of them are also going to fail and are not providing value. If we were to talk about drugs, we would have a standard. We would show that please do a randomized controlled trial or other rigorous evidence to demonstrate value. But now being on the receiving end, and so various hats I have of all these companies coming before us saying, please, we'd like to offer you for our plan or for our employer population. It's a bunch of hot air. Like, you know, here we have this cool model, and we got this great app, and we got this and we got that. And on our end, we have no idea whether they're full of crap or whether they have something really amazing. And yet we continue to allow that kind of hot air to keep on going. And so one of my calls to this industry as a whole, and this is coming from government, from plans and others, is demand better evidence that what works and what's not. Again, we would never tolerate someone just saying, I have this awesome new drug, it's got a great molecule, it's going to change hypertension. We would say, show us the evidence. And yet somehow we're allowing so many of these companies to treat Americans, and we don't have that evidence that those really work. So when we talk about value, I think one of the things that I would call out is that the need for more rigorous evidence in this space of telehealth is really, I feel, very critical.
Amar, anything to add? I think it's a tricky one. Steve, you're right. We have often the medical model, an intervention. There's a new surgical procedure, a new compound. Show me that it's good because I don't want to hurt anybody. On the other hand, you go, what's the value of email, or what's the value of the iPhone? Beats the hell out of me. Other than you could sell a lot of them, et cetera. So it's this visionary balance between stuff that is just so different that it's really hard to put a value. There's no working experience with it either. So I don't know. I think there's a complicated confluence there. Yuri, why don't we get, we don't have a whole lot of time. Let's see what else we got on the listener line.
Sure. So Steve Lapkoff, sorry, Roy, go ahead.
Just one sentence. I just want to, emphasize the fact that we don't have a model to investigate something and establish concrete statistical ROI doesn't mean that it doesn't have value. It just means that we haven't successfully investigated it.
Yeah, fair enough.
Great. So I'm going to ask Steve Lapkoff Dr. Lapkoff has a question. Steve, go ahead.
Yeah, hi, how do you do? Thanks, everybody. Excellent panel, as I expected. John, it's lovely to hear you moderate. It's always fun to hear you run a panel like this. For the panel, I'm a clinician by training. I'm a cardiologist by training. And one of the things that sort of supplements the last comment is that in addition to finding value, I think one of the problems also is that we also need to try to avoid, like every Tom, Dick, and Harry or that wants to set up a telemedicine shop and bill for it can just go out and do it without appropriate training. You'd never want a cardiologist who just came out of training, for example, to go and pick up a catheter and go do a cardiac cath or place a stent. They need to be specifically trained in those instruments. I personally see telemedicine no differently than I see a cardiac catheter or a surgical scalpel or some new medical device. You need people to be trained appropriately in the use of these tools so they're used properly, and that, so that patients don't suffer from things being missed because somebody did too cursory an exam or couldn't do an exam when one was actually called for. I'd love to hear what the panel thinks of that issue, because I think there ought to be, specific training and perhaps even boards that would govern how doctors would use this so it's not abused or misused. And I'll stop there. Thank you.
Thanks, Steve. Reactions, comments?
I'll jump in. So I couldn't agree more. And there's definitely no consistent approach to this. And at one point we thought there would be accrediting boards that would then, insurance would then require people to have the certification. That didn't take off. But what, I guess it's been a couple of years now ago that I was on a AAMC board where we were creating standards around training for residents all the way up to faculty. And because what you're mentioning, it's not just about the technology, it's even around not only the exam, but even the handoffs. When should I hand off and how do I do that when I'm in a virtual visit? And so that was the start of a framework to start building in that direction. But we don't have any enforcement of that by any means, but there's definitely a big array of sophistication and maturity of how people deliver this. We do training, but that's, everybody has their own approach to that and there is no standard.
Yeah, I just want to add that the examples, it's not only training about telemedicine, it's actually the rules, the standards of practice are changing around them. If you gave the cath example, if a patient is undergoing cath and is in the hospital, there is a certain expected length of stay to follow up on them before they get discharged home. How will that change if you know that you can actually follow up on that patient that afternoon at home and see them? Would you discharge them a couple of hours earlier, or potentially a day earlier if it's a cabbage or whatever it is, if there is a notion of follow-up? These have huge implication on the financial cost of managing, length of stay and all of that kind of stuff. But these are really medical practice guidelines that need to change when we think about surrounding patients through technology. So absolutely, there's a lot that needs to be done in that area.
What else we have?
So picking up on some of these questions in terms of financial incentives, I was struck by the comment, right? We have challenges in the number of providers. And, I think we've seen healthcare workers leaving the field. We have a growing population. Specialists tend to be in larger cities. And so I was wondering, in terms of, since we only have about a few minutes left, what do you think that the legislation to allow cross-border licensing is one of the biggest impediments to it? And if not, what are the biggest impediments, barriers that is preventing us from getting this telemedicine to really get to the next level? So maybe if we could go around and people could talk about, that, but any other, what do they think are the biggest barriers going forward?
Maybe I'll jump in.
Go ahead, Nadeem. Yeah.
First, I want to emphasize that I don't know biggest. It's always hard. A lot of barriers in this world, but I do think the cross-state licensure is a major issue. I think it requires and demands change. I've been frustrated by how slow it is, and I think one of the things that in some of our empirical work that I think is useful to emphasize is that a lot of it comes up with the example, and I think appropriately, I think Roy brought up the example of the person in many states away getting cancer care from a person at Dana-Farber. And I think that kind of care is critical. But in our work, we also say that it's a lot of bread and butter stuff, that people happen to live near a state border. Their primary care doctor is 3 miles away, but happens to be in another state. And their inability to use telemedicine across state lines is an impediment. So again, the point I want to emphasize is that this is not just super specialized care. This is bread and butter care that is going across state lines and is impacted by these laws. And I think it is a major issue on there. The only other thing I wanted, and you wasn't directly in your question, but I wanted to take the advantage of the opportunity regarding when we think about the lens by which we evaluate promising telehealth technologies. And this was prompted by your point that a lot of providers are leaving. And I think one thing we don't think a lot about is how much does this technology improve efficiency, that a single provider can manage more patients than they are currently. I think that for me is often the lens by which I think about the most exciting telehealth opportunities. Because when we start to allow a given cardiologist, a given mental health professional to really manage effectively more patients, I think that's when we start to really improve value and we address the provider shortage that we see in so many clinical areas in the United States. And that could be a variety of things from bots to other, using a team of providers, et cetera. But again, I want to emphasize that those telehealth new models that can improve efficiency, allow a single provider to manage more patients are the ones that excite me the most.
Other comments, panelists?
Yeah, I want to speak up. The first thing I want to say is that the issue of interstate licensing comes up at several levels. One is at the level of medical doctors. It also, there are separate regulations by state for nurses. There are also separate regulations by state for physician assistants. There are also different rules for pharmacists. So it's a whole different layers which we have to deal with, which is currently a mess. Now, in the case of doctors, there is a concept of a telemedicine compact. Many states are members of it. Massachusetts is not a member of it. So they've tried to take care of some of those problems. But again, just as other countries have gone ahead and made pacts across country lines, here we are far behind. We haven't even done it at the state lines. We need to really formalize it and make it much more smooth. Canada, for example, gives a national telemedicine license to people. We are not doing anything of that nature. A lot of work needs to be done. And my feeling is, instead of going piecemeal, is to really try out cases and really invoke the interstate commerce clause, just as I suggested, which is probably one of the ways to grapple with this issue, which is continuing on. So those are my quick reactions to it. And also, I think that there are no standards laid out. We have written one paper about doctors, and the other paper we have written about nurses and physicians assistant and pharmacists. There's a lot of work to be done in both these areas in order to really make them be used effectively.
Other comments?
Just,
quick one, Yuri.
just-
Go ahead, Christy. Yes, please.
Just really, I'll be super quick because I think that I'm just going to build off of not licensure, but just state variability, period. It'd be like driving in Texas is on the right side of the road. The next state you get on the left side of the road. And let me give an example. In some states, you need to see somebody in person within the year before you can treat them. And the next one, you can't do audio. And the next one, an NP can practice, and then another one that can't. To keep up with that and manage it to be effective is not going to work. We've got to get some more consistency.
Maybe I think it's a concerted campaign over long periods of time, just like the changing, you had to put ink on paper for prescription. Now you can do it electronically. That was a, state by state march through a lot of things. Yuri, we may have time for one more.
Yeah, one more question. So Leanne Rosenblitz, please ask your question.
Thanks, Yuri, and thanks to the panel. Terrific discussion and critically important topic. As you all described the boundaries of telemedicine and how it needs to be defined as going beyond televisits, I think it's a very important conversation. But it struck me that it's sort of, I lost clarity on what those boundaries ought to be, right? So how do you make them not isomorphic with just information technology about health, right? So you want to define, sounds like you want to define telemedicine in some way that is broader than televisits, but like narrower than telephone calls and fax machines or EMR systems. We may not have enough time for this, but if anyone, either Roy or Christy or anyone else on the panel has thoughts about what the appropriate boundaries of telemedicine are, I think it'd be really helpful to hear. Thank you.
Let me try to answer it. The definition that I have used is that over time, all healthcare is going to use a three-pronged approach. The three prongs would be people in proximity to you, maybe a family member, maybe a nurse practitioner, maybe a primary care doctor, a specialist at a distance from you who will be the domain specialist who may be in another state, another country. And the third would be the use of information technologies, modern information technologies for communication and for other things. The use of any of these two technologies or any of these two prongs of the three prongs makes it a case of telemedicine. So it would be either people in proximity and at a distance, or it would be the use of information technologies. And that's the way I define telemedicine, any use of any two of these prongs.
Christy, Roy, Steve, anything to add?
Yeah, I would say that if there is a way to do perimeters, around it, and maybe they're going to be tied to reimbursement and whatever it is. It needs to be on the modality, because frankly, I think the innovation of what travels over telehealth needs to be left at the hands of the clinicians. It is up to them to decide what's the best use of modalities to surround the patient that they're seeing based on their literacy and availability and all of that kind of stuff. We just need to kind of back off from the notion that telehealth is a kind of medicine, and rather think of it just as another tool in the hands of a clinician to care for their patients. That's it.
That's terrific. Let me go ahead and wrap this up, because we have about 1 minute left, and you all have busy days to go off into. First of all, let's thank the panelists, either using the applause symbol or showing me your hand. But anyway, thank you, panelists. Nicely done. It's always a great pleasure to see you, and as always, you guys were terrific and insightful and very thoughtful, etc. Also, I want to thank you all who attended this thing for attending. I hope this was informative and you learned a lot. Again, good to see you, although I don't really see you, but good to have you here. And Yuri and team, nicely done in putting all this stuff together. So thank all of you for being here. I think we're at the beginning of a very exciting journey. I think on the question of where's the boundary, in a couple of years, that won't really matter, because it'll blur. It'll blur into all kinds of other stuff. It's, and the sort of where the EHR stops and the telemedicine picks up, or AI stops, and it won't really matter because it's just all part of a highly integrated set of technology and set of use cases. So with that, Yuri, I'll turn the floor over to you, but I think we're done. But thank you all.
Thank you, everyone, and terrific discussion. The video will be available on the DCI Network website, and so we look forward to engaging with you further in the future. Thanks again, and have a great day.
Thank you.